The following video highlights the experiences of Doctors Conti, Weaver, Hingorani, and Molnar during their site visit.
Hi, I'm Mike Conti, Chief of Vascular Surgery at UCSF Medical Center. We participated in the pilot phase of the new ACS SVS Vascular Quality Verification Program. This is a comprehensive, productive, and highly rewarding experience that allowed us to deeply examine and organize our overall systems of care for every type of vascular patient in every venue in which they're cared for throughout our health system. The process really involves a deep dive into all phases of care for vascular patients, from preoperative assessment to perioperative and operative care to the post-procedural environment and the quality assessment and quality improvement cycle. It enabled us to organize ourselves into groups focused on specific areas of vascular disease, such as aortic, peripheral vascular, dialysis access, and venous care, to reach out to our colleagues across other specialties participating in the care of these patients. And very importantly, it engaged leaders from throughout our health system, from the executive suite through the departments, through nursing and administration, bringing everyone together to be engaged around what we're doing in vascular care and to ensure that we are providing the highest quality for our patients. This is a highly educational deep dive where we really looked at our QI processes. We identified areas such as linking to our EMR for our clinical pathways, improvements in ERAS and prehab programs for vascular patients, and opportunities to address resources and facilities and staffing together with our leadership team enabled us to really put together a comprehensive assessment of the current state of our program. I deeply recommend this program to all of you who have a comprehensive vascular center. It is really a great opportunity to do a complete and comprehensive self-assessment and engage all of the leaders in your medical center.
Hi, my name is Anil Hingorani. I'm a vascular surgeon working here in South Brooklyn, New York. In October 2021, we had our virtual Vascular Verification Program site visit under the auspices of the American College of Surgeons and the Society for Vascular Surgery. It really allowed us to organize what we were already doing and systematically review our program from beginning to end. Of course, we already had certain protocols written down, but really got to update these protocols involving the pre-procedure, intraoperative, and post-procedure. We really got to focus on demonstrating what we were already doing every day, and it really brought together a lot of our resources, including nursing, the vascular lab, the OBL, our front desk, quality, research, compliance, and regulatory. We had had prior site visits from various organizations in the past, but this one we found to be quite pragmatic and focused on quality. It identified some of our strengths and some areas for improvement, and allowed us to be critiqued by an outside set of eyes, which is always useful. In the end, we really got to appreciate the great team that we have and the individual contributions from our committed staff. We learned a lot and appreciated the process of the site visit. Thank you.
My name is Fred Weaver, the director of the Vascular Center at Keck Hospital of USC. We were part of the pilot of the Vascular Verification Program. The American College of Surgeons has asked me to provide a little insight into our experience at Keck. First of all, I would say that the process is a lot of work, but it's a very rewarding process. The document that is completed prior to the visit is incredibly comprehensive, and I think covers all the bases with respect to providing vascular care in the inpatient setting. I found it helpful because it engaged our quality department and administration at our hospital in a very specific way, all pulling to provide a positive visit by the vascular verification team. And it acted as a self-study for us. And in fact, I found out a lot of things about what the hospital was doing from a quality perspective that affected vascular surgery that I wasn't aware of. So the process allowed for a framework for organization of our vascular center in a much more comprehensive and detailed way. We have used that visit to springboard to a much more structured approach to our care for vascular patients and the quality of care that we deliver for our vascular patients. So I think it's just been a spectacular visit for us and experience for us. And I would encourage all of you to strongly consider having vascular verification for your center, either inpatient or outpatient. Thank you.
My name is Robert Molnar, and I'm a member of the Michigan Vascular Center in Flint, Michigan. I'm sitting in one of our OBLs, and actually it's the first OBL we started in 2005. It's probably one of the first in the country, but after we got going, we started a second OBL in 2013. When we started our OBL in 2008, when CMS allowed for payment for peripheral vascular procedures in the office-based setting, Blue Cross Blue Shield of Michigan required some sort of certification if conscious sedation was to be utilized. Well, that was written, and even though they don't enforce it, we took it to heart and we went out and got AAA HC accreditation, which is costly, time-consuming, and really not vascular specific. So when the SVS and ACS started to work on a verification program for vascular centers, and they were specifically looking at the outpatient office-based setting, I was very excited to participate in that process. As we identified the standards and put the program together, our site at the Michigan Vascular Center was one of the first beta test sites for this program. And I'm happy to report that since we had gone through certification before, it wasn't new to us. It was comprehensive. It did take time. We already had a lot of policies and procedures in place, but it really made us look at our system and really identify areas of improvement. And so quality improvement is a very large part of this process. Certainly after going through the process and taking the time, we recognized areas where we could be better. And I think this program with the ACS and the SVS together, we now have a vascular specific program, one that we can tailor make to our outpatient procedures, at least in the OBL side of service. And that will continue to provide quality, safety, quality improvement for our patients and our communities. So thank you for allowing me to share my experience with the SVS ACS verification program, and look forward to working with everybody as they develop their verification program for their centers.
The goal today is to present an overview of this newly launched ACS SVS Web Vascular Verification Inpatient Program and the outpatient program that will be launched in the fall of 2023. We've designed this webinar for a wide audience, and hopefully everyone in attendance will gain a better understanding of this exciting national quality program. The Vascular Verification Program establishes a cohesive framework for hospitals focusing on using data and quality improvement practices. This allows them to deliver appropriate clinical care and to achieve optimal vascular patient outcomes. The program provides participating hospitals with a way to establish and grow quality improvement and clinical care infrastructure for vascular surgery and for interventional care. Verified hospitals will have a framework for improving patient education, clinical care, and data collection, among other areas. The verification program can also be adapted to a variety of inpatient hospital settings. Our learning objectives for this webinar include reviewing the program in relation to clinical outcomes, describing the program and the 4 guiding principles of continuous quality improvement, and providing an overview of the inpatient and the outpatient program, process, and value. We hope the opening video provided you with some initial thoughts on the Vascular Verification Program, and we will continue now with our first presentation. So our first speaker is Dr. Clifford Coe. Dr. Coe is the Director of the Division of Research and Optimal Patient Care at the American College of Surgeons. He oversees all the quality improvement programs, including the Bariatric Surgery Accreditation Program, the Cancer Accreditation Program, the Trauma Verification Program, the Surgeon-Specific Registry, and the American College of Surgeons NSQIP database. He is also overseeing the new Vascular Verification Program. Dr. Ko is a double-boarded surgeon, his practice focusing on patients with colorectal cancer. His scientific research interests are in surgery, cancer, internal medicine, emergency medicine, and general surgery. He has published in the surgical quality of care era, as well as quality improvement and patient safety. Unfortunately, Dr. Ko could not join us live. However, we do have his pre-recorded presentation that we will play for you now. Over to you, Dr. Ko.
Hello. I'm sorry I'm coming to you by recorded video instead of live or virtually live, but I do hope to see you all in person soon enough. My name is Clifford Ko. I'm the Director of the Division of Research and Optimal Patient Care at the American College of Surgeons, or it's better known as the Division of Quality. I want to welcome you and provide you some context, history, and background on the American College of Surgeons' efforts in surgical care measurement, evaluation, and quality improvement. I've been the Director of the Division of Research and Optimal Patient Care for over 15 years. And during this time, we've developed close to 20 quality programs and registries. It's been expanded to over 4,000 sites and 2,500 hospitals, which together includes thousands and thousands of surgeons, of surgical teams, and millions of patients. We've set standards, we've advanced care, we've improved efficiency and effectiveness in many difficult, complex areas within surgery. We've conducted federally funded research from grants from the NIH, AHRQ, PCORI, and others, focusing on care models, implementation, statistical techniques, and other things. But most importantly, we've demonstrably improved care and outcomes for the patient. Some examples include in trauma centers where there's lower mortality demonstrably in trauma centers than in non-trauma centers. In bariatric centers, we know there's more weight loss, more effective resolution of comorbidities like diabetes or osteoarthritis. There's lower costs, and there's more rescues that occur in bariatric centers than in non-ACS bariatric centers. And in our breast centers, there's better breast care and outcomes for patients with breast disease. The fundamental tenets have been 4 things that we've done to develop these quality improvement programs. First, we've defined standards both in terms of the structure and in the processes of care. Second, we've ensured appropriate and adequate infrastructure at the locales. Third, we've used data from clinical registries instead of the often vague administrative claims data. And fourth, we've conducted verification. We trust, but we also verify. It's always been our collective aim at the American College of Surgeons to work with other expert surgical organizations like the SVS to progress surgical care and outcomes with these quality programs. Importantly, we continually use evidence, data, knowledge, and experience to generate even more evidence, data, knowledge, and expertise. Over the past decades, we have learned how to achieve this using our framework for achieving surgical quality. I am fully confident this newly released program for vascular surgery will achieve these seemingly lofty, yet demonstrably realistic goals. We're excited to be working with the SVS, so thank you. Thank you again, and I look forward to seeing you live in person before too long. Take care.
So thank you, Dr. Ko. So our next speaker is Dr. Tony Sadawi. Dr. Sadawi is a friend of many of us. He's a professor in the Lewis B. Saltz Chair of the Department of Surgery at the George Washington University Medical Center. He is currently the chair of the Vascular Verification Steering Committee. Dr. Sadawi is the past president of the Society for Vascular Surgery, the Society for Clinical Vascular Surgery, and the Eastern Vascular Society. He served on the Vascular Surgery Board of the American Board of Surgery and on the Board of Governors of the ACS. He has served on the Quality Committee of the Board of Regents for over 6 years. He has been a member of the ACS Board of Regents since 2015 and was elected to be the chair last year. In addition, he has served on the ACS Patient Safety and Quality Improvement Committee and the Surgical Quality Alliance. As the vascular regent, he worked with the SVS and ACS to initiate the work on the Vascular Verification Program that was launched on March 23rd, 2023. Dr. Sadawi has published over 150 peer-reviewed articles and he has served as editor-in-chief of the Journal of Vascular Surgery for more than 7 years. Dr. Sadawi, welcome, and the screen is yours.
Well, thank you very much, Dr. Forbes. It's really a pleasure for me to talk with you folks tonight. This is what you call a labor of love to put together this program. And actually, the Society for Vascular Surgery started about 25 years ago, thinking about putting a similar program. We had many obstacles at the time. Few of us were involved in it during all these years. But then about 5 years ago, we thought with the experience of the college and the infrastructure that the college has to put together quality program, and obviously with the Society for Vascular Surgery, where we are the expert actually in that area, we can put together a program that would look at and improve quality in various hospitals around the United States. So this partnership, we believed, really was made in heaven, so to speak. So I'm gonna talk to you a little bit about how we put that program, the program together. We're very excited that it's launched, and I hope that most of you will consider it seriously for your hospital and your organization. In the beginning, we really needed a lot of work to put the standards together. So as you see here, this was our original organizational chart. A lot of people were involved, and I would like to thank them all. Currently, however, now that the program has launched, we kind of tightened up the group working on it. And also, I want to thank these folks for their work and their continue to work with us on this program. Now, I'd like to provide special recognition to a few people. First, Dr. Kim Hodgson, who was the SVS past president, for his effort and work on this program for its inception up and including the final pilot site visits, or what we call the beta phase of this program, which you will hear that's extremely important. And also I'd like to thank Dr. Ken Slaw, who's the executive director of the SVS, for his support throughout the process, and also other SVS presidents who during their tenure never wavered in their support of this effort, to include Drs. Macaroon, Dalman, Abu Rama, and Dolsing, obviously, in addition to Dr. Hodgson that I've already mentioned. On the ACS side, I would like to recognize Dr. Patricia Turner, who is the current executive director and CEO, and definitely Dr. David Hoyt, who is the immediate past executive director of the American College of Surgeons. In addition, Dr. Cliff Coe, that you heard, who is the head of the quality committee of the college. All of these folks contributed significantly to the collaboration, inception, development, and launch of this program. As you briefly heard from Dr. Coe, all the programs at the college are based on 4 guiding principles. Put standards together, backed by research, and in our situation in Society for Vascular Surgery, we're blessed that the Society published many reporting standards and many practice guidelines on all areas of vascular disease. So we use those as a backbone for our standards. And then based on these standards, we'll put together the right infrastructure. And this is extremely important to have the right infrastructure, which includes staffing levels, specialists, equipment, checklists, all that stuff. And then actually have the appropriate data. And we are very lucky in the SVS that we have the VQI program, because if you look at other programs that were put together by the college, some of them, they had to have basically a registry put together from the ground up. And here we have the VQI, and obviously there is also the NSQIP at the college. And at the end, which is extremely important, and that's the external peer review visit, which used to happen in person, but during COVID, actually, we learned how to do it virtual, and it worked very well. I'll talk briefly about it. And by doing all that, and once a hospital becomes verified, then we believe that it will create public trust. And when they go to that hospital, that they're getting the best care available. Now, the standards, when you, in the beginning, when we put them all together, we ended up with 92 standards. And obviously that's too many standards. So we shrunk them down, we merged them, we actually decided some of them were not going to be that useful, but we shrunk them all to about 48, 49 standard. But in order to have control over them, we divided them into 9 domains. And these, as you see here on the screen: institutional administrative commitment to the program, program scope and governance, facilities and equipment resources, personnel and service resources, patient care, data system surveillance, quality improvement, education, professional and community outreach, and research, which is basic and clinical trial, although research is really not necessary to have in every program that we verified. So these are basically the standard. The slide is not for you to read it, it's just to give you the extent of which this program, which is a quality-based, quality-driven program. This is not an administrative program. This is a quality-based program, which that's what's important to us as vascular surgeon and vascular specialists. And so we launched, as you heard now, our inpatient program. The outpatient program will be in the fall. So in the inpatient program, we have 2 levels. We have what we call here the comprehensive inpatient program, and we have the verified inpatient program. The difference between the two, that in the comprehensive, there are 4 areas that are performed, that are aortic arch and proximal brachiocephalic vessels, descending thoracic aorta, visceral aorta, and thoracoabdominal, and visceral aorta endovascular. Now, everything below that is shared between the comprehensive and the inpatient, whether it is descending thoracic aorta and so on and so forth. Now, in every one, and once you download what we call the book, the standards book, and it's easy to download. We'll show you at the end how to do that. For every standard, there is actually the definition and requirement, as you see here for this one, which is standard number 1, is the hospital commitment, and then the documentation, what's needed to document in order to comply with that particular standard. Now, we moved to verification visit, which now we're doing it virtual, and actually we proved through the beta testing period that virtual can work well, and I will tell you how we do it. But during the visit, we basically touch on all the 5 phases of care. The 5 phases of care in surgery is pre-hospital admission, hospital immediately before surgery, after the patient comes to the hospital, and then intraoperative, and then immediately post-operative, and then post-discharge. And we touch on every single phase of this during our visit. And we actually also use vascular specific protocols that, as I said before, they are put together by the SVS, our society that we all, most of us, the vast majority belong to. And again, this program supports registry use in this situation. The primary one is VQI and case review evaluation. Incidentally, let me say, that's the difference between VQI and this program. A lot of people ask me when I give a talk about this, say, well, we already have the VQI. That's true. The VQI is a database, but this is a verification program that include the four domains that I described to you, which are the basis of all college quality programs. Now, the verification process itself, we do the virtual visit by video. So the center will send us a video going around their center and describing what they have. They go through the clinic, they go through the vascular lab, they go through the radiology suite that they use. They go through all these areas and they show us basically, and they describe them to us all on video. And that video could be between 20 and 30 minutes. And then there's a pre-review questionnaire that's based on the standard and it can be downloaded. And that pre-review questionnaire is basically filled in by the program and the program leader or his or her designee and sent to us ahead of time, and along with documentation that's required by the standards. And then they choose 50 to 60 cases based on type of procedures, complications, surgeons, and different surgeons in the center for the reviewing group to choose 10 from these 50 to 60 cases to discuss during the site visit. So we basically sit there and have a conversation about every one of these 10 cases, and we discuss and we see whether there are trends there that we need to be talking about. And then the verification visit itself, we meet with the surgeon leader, the nursing and staff, anesthesia, hospital leadership. We meet with the CEO, the COO, the CMO, the CNO. And that's extremely important because we want them to know the extent of which we are looking at their program. And we want them to know that is what kind of support a successful program will need. And you will hear a little bit about that later on in the presentation, how program leaders leveraged actually the information to get support from the hospital. And then we review the selected cases with the surgical team, as I mentioned. And then at the end of the day and a half, and the inpatient will take about a day and a half of a virtual visit, we do a summation. In that summation, everyone will be there, the CEO, the leadership at the hospital, the leadership of the program, and they will hear from us directly how the program fared and what the program needs in order to get to that next step. And then we write the report and we provide it to the center within 6 to 8 weeks. So we put together the standards, as I showed you, and then we wanted to test the standard. So we chose 4 inpatient sites and 4 outpatient sites. And those actually volunteered, and we thank them profusely that they've submitted their center for review. On the inpatient side, we had Albany Medical Center, Baylor Scott and White, UCSF, and you heard from Dr. Conti about that, and USC Keck, you heard from Dr. Weaver about that. Also, the outpatient pilot sites were Michigan Vascular Center, you heard from Dr. Molnar, and also the Albany Medical Center. Albany submitted both their inpatient and outpatient centers already. Nashville Vascular and Vein Center and the Total Vascular Care in Brooklyn, and again, you heard from Dr. Anil Hingorani from that. And we used what we learned from these to actually refine the standards. So this is the first site visit that we had, and we kind of took a screenshot to memorialize it. And this is what we call the inaugural visit, which is Albany. You will see here Dr. Darling, you're going to hear from him soon. That's his program. And you'll see here Dr. Ko, Dr. Hodgson, Dr. Hingorani, and Dr. Conti. And actually, that was Dr. David Hoyt and myself down here conducting that visit. And others were attending to learn so they could start reviewing and conducting the visits in the future. So this is where I'm going to end. And since I mentioned that Albany was the first to allow us to come and visit their program, I'm going to stop here, and Dr. Darling will be following me. Thank you.
Great. Thank you, Dr. Sidawi. So as a reminder to our attendees, please use the Q&A button at the bottom of your screen to submit your questions at any time for any of our presenters. We'll try to answer some of them as the webinar is going on, and we'll save some for the panel discussion at the end. So our next presenter is Dr. Clem Darling, who joins us from the Albany Medical Center and Albany Medical College. Dr. Darling is the Chief of the Division of Vascular Surgery at Albany Medical Center Hospital and Director of the Institute for Vascular Health and Disease. He was the past president of the SVS and New England and Eastern Vascular and Endovascular Society. He is currently the chair of the ACS SVS Inpatient Verification Program and the Vascular Group in Albany. Dr. Darling is one of the leading vascular surgeons in the country and has been recognized for objectively evaluating outcomes based on the data collection registry to optimize patient care, especially in peripheral interventions and peripheral bypasses. Dr. Darling has over 200 publications. His areas of expertise include arterial insufficiency, aortic aneurysms, aortic and thoracic endografts, peripheral and arterial disease. Let's just face it, it's all aspects of vascular surgery. So over to you, Dr. Darling, the screen is yours.
Thank you very much, Dr. Forbes and Dr. Sidawi. It's really an honor to be here. As Tony outlined, we were one of the beta sites for both the inpatient and the outpatient, which was really incredibly valuable for us in that we could document everything that we've done over the past 20 or so years in creating a vascular system. I'm going to talk a little bit about our experience. Oops, trying to advance my slides. And what benefits we saw and what lessons we learned from it. One of the more important ones is that it really allowed us to show the process that we have to go through in order to take the best care of vascular patients. There are many things we do that we really don't recognize. There are many things that the hospital needs to support in order for us to get the optimal care. And in preparing for the site visits and the inpatient and for the outpatient, it was extremely valuable. That one of the other things that was helpful is it helped us coordinate with our nursing staff, with our education staff, with our data registry, and with the hospital nursing staff and ancillary help, and providing a seamless approach to how we do our care and to document it. Now, one of the things I think we found important with this as we went through the process in evaluating other centers is that we all need to have a shared responsibility and a bar that is set for the quality of care that we provide. And in having us go through this beta test, we could use and learn from other institutions and other systems on how they deliver care. And so we don't all recreate the wheel every time we go through this. So part of the process is going to be to share our data and share our protocols and how we do things amongst ourselves to make this process seamless, but also more importantly, to have a consistency in vascular care throughout this country. Again, I think the most important thing we found is that this report actually gained us leverage for getting resources from the administration of our hospital. Again, we've had a relatively large, vigorous system for 30 years, but the institution did not really understand what it took to provide this type of care and how the processes that we have put in place in order to give this care. Also, there are many parts of the infrastructure that are incredibly important for us to provide vascular care and to provide care for other services in the hospital that have been poorly recognized, such as helping many of the other subspecialties in complicated cases, how to rescue, and how to provide instantaneous help when they need it. We're also able to help refine the standards by doing this. The standards are based off of our guidelines written by vascular surgeons. And when I was the president of the SVS, we were approached by a lot of states, especially for the outpatient process, because they had no rules and no laws. And many of the rules they were making up did not correlate with the kind of care that we provide. So having the standards on the guidelines is extremely important and creating these standards, which again were created by vascular surgeons who know how to take care of vascular patients. Now, another insight that we found was that peer review is also complicated, especially in outpatient facilities when you have a small group. So we're looking to establish a national peer review program in order to help those groups who have don't have enough people to create an objective insight into some of the complications or problems within their facility. This way we can do it in a positive, constructive manner, show some of the protocols that other institutions have used, and be able to bring everybody up to the same level, and also to help them with complicated problems or complicated infrastructure issues, and how the solutions were derived from other institutions. And as Tony correctly pointed out, the verification visit was very amenable to the virtual environment. It was a huge cost saving. For the outpatient, it takes about a little less than a day. For the inpatient, it was about a day and a half of our time in order to get this process complete. This is a living document also. So many of the time we learned that some of the outpatient standards need to be adjusted in order to make them functionally useful and valuable for everybody. And I think this is, again, a unique process that we're going to continue to develop and to continue to work upon. This will allow us to move seamlessly with new technology, and also with new also objectively evaluate the outcomes of many of our procedures as technology is improved within vascular care. And now, importantly, you've seen the list of the reviewers, or you will see a list of some of the reviewers that we have. As you go through each program, one of our desires is that those that can provide a person or two to be part of the team in order to be reviewers. The reviewers will be required to complete a formal standardization training prior to serving as an observing reviewer role, and then can be placed in the senior reviewer role also. I think this will be helpful for vascular surgery in order to create it, to establish it as a distinct specialty, and it will be very valuable to help us mandate that vascular surgeons need to be the ones to observe and to evaluate vascular surgeons. Sorry, it's not advancing, but again, to reiterate that point, vascular surgeons perform the evaluation. We use SVS guidelines. We have an overall vascular program evaluation, which can be used as a document and as a pro forma to go to your institution. As we give the analysis in the completion of the evaluation of your program, we ask you, prior to talking to the CEO, of what you think your needs are and how we think we can help you create a better program for you. And I think this was one of the most important things that I know Mike Conti found and we found in our program, especially for especially for the inpatient program. This is, again, as it's been reiterated, a QI focused. This is not just a checkbox system to make sure you have the correct equipment. This is a quality improvement focused system where we are supportive of registry participation. Obviously, VQI is an important adjunct to this, but it does not necessarily have to be VQI. But we want to see some objective evaluation of your outcomes, and we will help you work in a system that can create that's reproducible and objective. Again, the verification visit will be virtual. It takes about a day and a half, or maybe a little less for the inpatient, and less than a day for the outpatient. The metrics that we're going to be evaluating on are the documentation of what you need as far as infrastructure, but also looking at some registry data to confirm that the results are reasonable and meet the quality needs of vascular surgery. Again, this is for patient safety and quality, which by far is the most important part of this for our patients, and trying to create a system that there is a water line or a level that we expect vascular care to be provided around the country, whether it's inpatient or outpatient. Now, probably one of the question that most of you are asking is, how is this important to your hospital and how can you sell it to them? We all know that vascular care is a team sport requiring appropriate infrastructure. One of the things I think I've learned from working within a relatively large vascular care network in upstate New York is that it's not just the people that are important. It's not just the surgeons that are important. It's the people that work together, the nurses, the techs, the vascular techs, the angio techs, and the hospital's buy-in that is important in order to create the best atmosphere for taking care of your patient. This document that you are going to create organizes and validates all the work you do in the care of the vascular patient and shows to the administration that how much work you've put into creating a system that makes them look good. It especially demonstrates to the C-suite the value of your vascular system to the entire hospital, much like I mentioned before of how we help all the subspecialties within the hospital decide on appropriate care, appropriate intervention, and also help them when there are complications, operative complications or procedural complications in the hospital. It confirms the tremendous amount of effort that is needed to provide this vascular service and the tremendous amount of work that your staff provide to the hospital. And it allows us to ask objectively for the needed infrastructure for the best care and for the best practice. And again, once to reiterate, this is not a quiz for people. This fairly extensive document is a method for us to organize our thoughts as vascular caregivers, but also to share that amongst ourselves so that if there are protocols that you may be lacking, we can help you create them or provide them when we go through this protocol. As I mentioned, assisting in coordinating of vascular cares with the standards, protocols, and outcomes, and encouraging sharing of ideas and consistency of vascular care around the country, which is a much needed process, especially when you can see some of the care that's given in places with non-board certified vascular surgeon. And this, I think, equally as important, it promotes branding of vascular surgery as a distinct specialty. This gets us out of the realm of just being a subspecialty, but we are a specialty amongst ourselves. And by having a system and a program that validates that, I think is extremely important for vascular surgery, especially for the future. Again, I'd like to thank all the process participants within this, Tony Sadawe, David Hoyt, who was the past director, Cliff Coe, Bill Schutz, Anil Hingorani, Kim Hodgson, who was one of the forerunners of this, Dr. Tom Forbes, Erica Mitchell, Kelly Brown, Fred Weaver, Larry Kreis, Dennis Gable, Linda Harris, Mike Conti, and Rob Molnar, who was the first group to be looked at as an outpatient. Lastly, the responsibility of the reviewers. They should be a committee member or in process with a vascular application at their home institution. They need to complete a formal standardized site reviewer training, stay current on standards, program requirements, and process and review process, and commit to conduct at least 4 or around 4 site visits per year. And if you're interested in applying to become a reviewer, here's the QR code, and please submit an application. It's, I think, extremely valuable for the reviewer as much as it is for the reviewee, and we learned a tremendous amount by reviewing these 4 beta sites.
You are muted, Dr. Forbes.
Thank you very much. So thank you very much, Dr. Darling. Our final presentation before we go to a panel discussion is from Dr. William Schitz from the Texas Vascular Associates. Dr. Schitz is a vascular surgeon in Plano, Texas, and is affiliated with multiple hospitals in the area, including the Baylor University Medical Center, the Baylor Scott and White Medical Center in Dallas, the Baylor Heart Hospital, and the Baylor Regional Medical Center in Plano. Dr. Schitze has held numerous leadership positions at the SVS, including the SVS Board of Directors, the chair of the Clinical Practice Council, Community Practice Committee, and the Mentor Match Program, as well as the SVS Foundation and Communication Committee. Currently, he is an officer of the SVS, serving as our society secretary, and is also chair of the outpatient Vascular Verification Program. Dr. Schitze's practice focuses on the advanced treatment of thoracic and abdominal aortic aneurysms, visceral renal artery aneurysms, and peripheral artery aneurysms. He has published over 100 papers. So welcome to the podium, Dr. Schitze. The screen is all yours.
Thank you very much, Dr. Forbes, and thanks to all of the speakers that went before me to lay the groundwork, so my part can be very, very easy. And in fact, as we're going through the time, I don't have many slides, so we'll be able to get to the meat of this, the Q&A, real soon, as there are a lot of great questions that are coming up in Q&A. Go ahead and share my screen and go. All right. So looks like we started it. Oops, sorry about that, folks. My Mac likes to do this. We're here. For some reason, I'm starting at the end. We're going backwards. Okay. The big question, right? Why outpatient verification? In fact, I think most people understand the value of inpatient verification, and there's a lot of precedents in many areas, trauma, stroke, et cetera, as to being, verified in the inpatient world. But why outpatient? Well, the short answer, and it's pretty, very simple and obvious, it just demonstrates your commitment to quality vascular care for your patients. But that doesn't really carry much weight. What really does it mean? Well, what it means is that you and your team are actively engaging in processes in all 5 phases of care for your vascular patients in the outpatient space. And this is reinforced by robust case review, in addition to creating a strong team with the same goals you have in providing high quality care for your patients. Okay, that sounds great. But what does that mean? Well, what that means is that if you go through this process and you become verified in your Alpha Space Lab or your ASC, you're now setting the standard for vascular care in the outpatient space in your community. That I feel is the real value in this. Now, that doesn't come without a cost, obviously, and without a lot of labor. So what other value is there that can make this worthwhile? Well, there's immediate and long-term value. Immediately, this addresses something that Dr. Darling had mentioned, is that several state regulators have identified that there is a void in this area of care in vascular disease in the outpatient space. And there were some misguided attempts a few years ago to try to address this. Luckily, the SVS was able to step in and try to put the brakes on several of these, misguided attempts to address the void in verification in the outpatient center. But that doesn't mean that this isn't going to happen again. And that's exactly the value that this program brings to vascular care in the outpatient space. What about a long-term goals? Well, this, we hope, will replace some of the other more general, non-vascular focused accreditation programs that are required in multiple states, which also require time and money. Why can't we replace them with a program that is strictly devoted toward creating quality vascular care in the outpatient space? And that's one of our goals. Prior authorization is a huge burden for everyone. And if we can demonstrate to the payers that patients in these in these quality centers are providing high quality care at a lower cost, then we can hopefully swing the pendulum of prior authorization back to something that's more meaningful and realistic to actually helping our patients, as well as letting the payers know that great quality care can be provided in the outpatient space, site of service 11, at a much lower cost, hopefully leading to preferred provider status and more traffic going to these high quality centers in the outpatient space rather than in the high cost environment of a hospital. So, to be honest, we are the first outpatient program with the college. They had not gone into this area before, and we're there helping them dip their toe in the water and understand the outpatient space for quality care. We surveyed our members, and I'd like to thank everybody that answered the survey last year as to their interest in the outpatient verification program. And as you can see, we had a robust response in favor of that. And then to the same respondents, we also queried them as to how many procedures were being performed in their labs. And you can see that we had some labs that were doing a tremendous number of procedures. So we have a lot of patients receiving care in the outpatient space, and we'd like to see all these patients, as Dr. Darling said, receive the same quality care nationally, not regionalized or localized, but nationally. We're all providing the same type of high quality care wherever we are. Now, there is a little delay in getting the program launched, and that's why it is not launching at the same time as the inpatient space. As I mentioned, this is a new area of work for the college, and it's taken us a little longer to get these standards finalized, but we're very, very close, and we're hoping for a fall launch. So this is the site on the college's website where you go, facs.org/vascular. So put that in your browser, and that's where you'll go to get to the Vascular Verification Program. Once you've done that and you're in the program domain, you can look at the processes, and you can also start the application. And I encourage you to do that. There's no cost to starting the application, so I encourage you to go ahead and start the process. Now, there'll be probably 10 or 15 seconds of awkward silence as I allow you to take a screenshot of this QR code, because this has the standards for both the inpatient and outpatient. So either grab your phone, take a quick screenshot, or if you're on a Windows computer, you can use the snipping tool to take that QR code and save it on your clipboard. On a Mac, it's Shift-Command-4, and then you can then save that QR code, and that will link you to the source to download these standards. I'd like to thank everybody that signed up and then attended this webinar. I hope you find it informative, and we'll do our best to answer all of your questions with the time we have left. Thank you, Dr. Forbes.
Well, thank you, Dr. Schütze. And thanks again to all of our presenters this evening. So I'm now gonna ask all of you to turn on your cameras and join us for a bit of a roundtable discussion. Hopefully everyone has had plenty of time to add their questions to the Q&A button. If not, please feel free to do so. At this time, we are also going to launch a quick poll, and you should see that poll pop up on your screen shortly. Please take a moment during our panel discussion to fill out the poll. So I'm going to ask some of the panel discussants here a couple of questions. There's a lot of excellent questions, and I'll try to paraphrase some of them in the remaining time. So Dr. Sadawi, Dr. Humphreys and others posted in the chat, how will the SVS and ACS partner with other national quality programs or payers or other bodies to make this verification mean something?
Yeah. Well, this is exactly why we collaborated with the ACS to put together this program, because the ACS, with its quality program, some of them go back about 100 years. If you look at the cancer program, and about almost 50 years now, if you look at the trauma program, actually they've been working very diligently with other organizations, and they are discussing all their quality program. And once they partner with such organization, this vascular program will be part of it. What we hope, if you ask me, what's my best scenario? Well, my best scenario is the following. If you participate and you're verified, you don't need pre-authorization. Okay, you do not need to be, the Joint Commission doesn't need to come and look into your area. You're already being verified. But that actually, because there's so many programs out there, this is gonna take a while for the college to be able to collaborate and work with all these agencies and different programs that are available for quality. But the college has started doing that some time ago. So this is why we decided to collaborate and work with the college on this program. And as the college is moving forward with these, hopefully our programs will also be, not hopefully, our program will be included in such.
Great, thanks, Dr. Sadawi. So next question is for Dr. Darling. And Dr. Darling, as you went through the process, how did your C-suite receive the discussion about the cost to initiate the program? Once the compilation of it is all done, they may see the value, but before then, they have to commit to the initiation cost. So maybe give us a lens on the discussions that you had with your organization.
Sure. We had warned them in advance that this was coming. We are the level 1 trauma center, one of the busiest in New York State, I believe. We have a bariatric center, so I think they've understood the value of the necessity of having the accreditation and going through the process. So the cost to them wasn't even though they lost a lot of money last year and due to COVID, they were actually pretty receptive for this. I think where they became very, very happy was when they had the final review and all of the positive comments that were made about the program. Also, they were even somewhat interested in finding out what we needed in order to make the program better and how we could and how they could be involved with that. So I think it was extremely valuable for them. The cost, nobody wants to pay extra money, but they had done it before for the other programs. And so they were fairly comfortable with it. They were very interested in having the accreditation and being involved in the program.
Great, thanks, Dr. Darling. The next question is from Dr. Kelso to Dr. Schütze. So what has been the reception or the acceptance of community hospital administration of this program, and similarly, the response of non-vascular surgeons, namely cardiologists?
Let me do the second one first, and that's an excellent question. And I think there is some concern about what do you do with your non-vascular surgeons colleagues providing vascular care? Are you providing blanket coverage for them to do their procedures, even though your service line is the one that went through the accreditation process? Your service line is the one that is following the rules. And I can just share with you that at my main institution at the Heart Hospital Plano, when we started down this pathway, we made it clear to everybody in the hospital that had privileges to do vascular types of procedures that they were going to be part of this process, and they were going to help with this process. And once that was laid down as an expectation, then I can tell you it's really helped us tremendously with a lot of the issues that the different service lines have in competing for vascular care and providing different types of vascular care. So we have now, when we have our conferences, our case conferences to review M&M, we call it PACMA. It's a multidisciplinary conference with cardiac surgery, vascular surgery, and interventional cardiology. And it gives us all a chance to really, again, make sure that everybody is following the protocols, that we have a strong peer review process, and that we also are able to talk about system processes that need to be improved or continually worked to maintain that high level of care. And I would encourage institutions that want to go down this path to try that approach. I don't know if that's what's been done at the other facilities, but I think it is the best way the best tool you have to get everybody in the vascular space under one service line. As far as the community hospitals kind of approach to paying for this, this is something we're going to find out over the next 12 months. As you know, all of the inpatient sites were academic medical centers, excluding mine. My hospital was very eager to get on board with this as a beta site. But that relates to more of the fact that it's an institutional philosophy to try to use quality as a high bar and in general. It's going to be a good discussion in the C-suite, but we're very happy to help you with the talking points and the bullet points as to why it's an important program to subscribe to.
Yeah, if I may add to that, Tom. We heard from different hospitals of the leadership of that hospital is that when they heard us at the summation session at the end of the program. And what we talked about vascular surgery, and we emphasized during that summation, the importance of vascular surgery to their hospital and to every hospital. Actually, a good number of them got very excited about vascular surgery, which they learn from us, actually, what vascular surgery is, what it can do. So there is an added benefit to the whole process. One leader of a department saw me at the college meeting, I'm not going to mention which one, and said, we weaponized your report and we got additional support based on your recommendation from the leadership of the hospital. So this can mean a lot to a vascular surgery program. Incidentally, very, very quickly, the reason actually I've been always itching to do it, because I look at trauma, I look at transplant, my gosh, I mean, the hospital put in so many resources in them, but nothing come to vascular surgery. Why? Because they have such a program. The trauma program said, if you want to be verified as a trauma center, this is what you need to have, and hospitals pay for it.
Thanks. All this is such a good news story. So maybe the last question, because Clem, your group is the only one who's gone through the inpatient and the outpatient verification program. And, you know, I'll use Dr. McGinnigal's question here as a bit of a segue. So she says, in her institution, she does not have any OBL. She brings patients to the major medical center for their outpatient angiograms, et cetera. And since these patients go home, they are often overlooked by existing inpatient QI initiatives. So what would you advise her? She asks, is there a role for major medical center to participate in the outpatient verification module? Obviously there is, since you went through it, but maybe you can describe that a little bit more.
Yeah, that's an interesting issue, because we still do a significant amount of inpatient angiograms, and those are actually covered under the, well, currently, before this program, they were not covered by anything 100%. So, you know, there was no true quality control. VIR, although we work in the VIR suite with our radiologists, they do have an M&M, but it really was separate from the one we're doing now. As Bill correctly pointed out, you know, the goal of this is to get everybody to work together and to get the results to be analyzed equally. So our patients that are done outpatient in the medical center are reviewed equally in the inpatient as part of the inpatient facility. And our outpatient in our OBL are reviewed in a separate M&M, but then that coalesces together for documenting the complications to our system. But they are two independent thoughts, independent analyses as it stands now. But in those patients that have the outpatient angios in the hospital, we review in our inpatient facility. Review.
Very good, Clem. And I see that there's still over 130 attendees, so people are starving for information about this program. Dr. Sidawi, maybe just a brief operational question for you. A couple of the attendees have asked, do you foresee a recertification process?
Yeah, actually, we do have a recertification process every 3 years, and or re-verification process.
Sure.
And like all other programs, if you have trauma program in your hospital, you know that every 3 years. Now, one thing I want to mention, which is extremely important, and I actually forgot to say it when I did my presentation. Hospitals are now saying that, how many programs I'm going to participate in? I got trauma, I got bariatric, I got this and that, and now you want me to have vascular, okay? So the college and the SVS are very cognizant of this. So there was a group that was put together called the Future of the Quality Programs, which I was a part of. And that group has been working on how to bring things together to make it more manageable for hospitals and even more cost effective. What we're hearing most from hospital actually is that we get site visited every few weeks. So the idea for the college program is to use the QVP, which is the red book okay, which that would be the basis of all the quality program. And instead of having multiple visits, the group from the college will actually do the QVP site visit, and then different specialists will do all these other programs based on the specialty. And in 1 week, get all the college program verified at the same time. So the college is cognizant about that issue and working very, very hard to see how we can bring all that stuff together.
Thanks, Dr. Sadawi. And maybe the last question, just a bit of an operational question for both Dr. Darling and Dr. Shitze. So a couple of people have asked about, in preparing the submission, how much time did it take? How much help did you need? How onerous was it? Dr. Shitze, maybe you want to go first.
Yeah, I would say that from the time we started till the time that we felt the PRQ was good enough to submit, that timeline was about 4 months. Now, how many man hours were spent on that? We recruited a lot of different individuals from different areas of the hospital to do the different parts of the PRQ. And I think that works a lot better than just giving the PRQ to your nurse, your PA, your NP, and say, here, take care of it. I think if you carve it out like that to the different areas, you're actually going to get some much better insight as to how the processes are in place and what needs to be improved. They'll also get a better understanding of how they're providing the processes to your patients that you want them to provide, and it leads to a better product overall. So it was somewhere between 50 and 100 man hours to get the whole PRQ done in a robust manner. We leveraged our we did not have written protocols, believe it or not. We had no written protocols for the different vascular emergencies for thoracic, aortic, carotid, and lower extremity emergencies. So then we partly those out to different vascular attendings, and we actually paired a vascular surgeon up with an interventionalist if there was a space where both disciplines were working. And so again, it brought everybody together on these protocols so we all could agree that these were the protocols, and this is how the institution was going to handle it. But it was a long journey just getting everybody to get their work done and compile it. So I would say from the time you get your PRQ and start, give yourself a nice timeline before you go ahead and pull the trigger and submit it to the college. And then once you've submitted it, then the clock starts ticking again, because there'll be a couple months after they review it, then you're going to have to start pulling cases for the case review component. And the case review component is very important. You learn a lot from that part of the site visit about your own institution. So that was our experience.
Yeah, one of the interesting things we learned is that there were a lot of protocols that we didn't think we had, but the hospital had. We work up in New York State where they have rules for everything. And so, again, like Bill correctly said, is we would ask the nurses in VIR, what are the rescue protocols down there? And we may not have had them, but they had them. We went to the transfer center to look through what is the exact contract they have with outside hospitals and how it would work. So I agree, it takes about 4 months. Well, the way we did it is we had my practice supervisor worked with me mostly, and then we we partitioned out and delegated parts of it to people that are, more commonly situated in that part of the hospital. But it really, again, brought everybody together. It made us realize how much we really already had done. And then we realized how many things we had to do. And we searched out to other institutions to figure out how they did things. And it raised the quality of care in our institution, and I think as well as others.
Dr. Sadawi?
There's one thing to consider, which we didn't have time to talk about. All reimbursement is moving from volume to value. We know that. And the government, little by little, is moving it, but it's getting there. All the ACOs and all these programs is leading that effort. So who is best? And value is basically quality and cost. Now, who is best to define quality other than us? If we don't define it, okay, we're going to have all governmental agencies, we're going to have all insurers defining it for us. So this is a huge reason why we jumped in to put this program together. We wanted to define the quality of vascular care for everyone. And, you know, if you look in the Q&A, actually, Dr. Dolsing, our current president at SVS, put there a very important paragraph, which I think it's worth reading. I'm not going to read the whole thing, but I just want to say it will show the C-suite and your colleagues just how valuable vascular surgery is to all areas of healthcare delivery. And that is extremely important, I believe, in addition to what I said about value and quality.
Well, thanks very much. And, you know, before we close the webinar, I'd like to remind our attendees that we will be closing the survey shortly. Please complete that now if you haven't already done so. I'll just echo the thanks of everybody for all those individuals that have put this program together. I'd like to thank our presenters this evening once again, Drs. Ko, Sadawi, Darling, and Schutze. And to our attendees, thank you for joining and participating with us this evening. The webinar has been recorded and will be available on the SVS website in about 2 weeks. And there is other information on both the ACS and the SVS website regarding this program. Please reach out to any of the panelists if you have any specific questions afterwards. And please have a pleasant rest of your evening. And thank you again for joining us tonight.